Welcome back to The World Tonight. Johnson & Johnson's vaccine booster just got the green light from an FDA advisory panel. The panel says the booster can be given as early as 2 months after the initial dose. Booster doses of Pfizer's vaccine started last month for people at high risk for COVID-19. And yesterday, the FDA advisory panel okayed Moderna's vaccine. Now, Johnson & Johnson is the third vaccine authorized for emergency use in the U.S. More than 15 million people are fully vaccinated with it, and it's shot according to the CDC. That's less than 5% of the U.S. population. The company's goal was 100 million shots in the first half of 2021. It was marketed heavily to communities of color as a one-off that didn't need refrigerated storage like the other two. But news headlines highlight why Johnson & Johnson's COVID vaccine numbers lag behind Pfizer and Moderna. Here in the U.S., black people are only about 30% fully vaccinated. Institutional racism and historical inequities in health care play a critical role in vaccine hesitancy among African Americans and other people of color. For a vaccine highly promoted to black people made up only 10% of people its clinical trials had been performed on. Same goes for Pfizer and Moderna, according to Johns Hopkins. Joining me now to break all of this down is medical ethicist Harriet Washington. She's also the author of Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present. Very important title, very important book. Harriet, if you will, people think the Tuskegee Experiment is the reason behind vaccine hesitancy today among Black Americans. We know that you don't think that. Please explain why.
It's less that I don't think that. It's not supported by the facts. We know it's not true. We know it's not true partly because people invoke Tuskegee because that's all they know. They're ignorant of the 400 years of history in which abusive experimentation has been the norm in this country, unfortunately. Thomas Leviste of Johns Hopkins published a series of articles investigating the question. He found out over 15 years ago that Tuskegee is not the reason why African Americans are hesitant to embrace medical research or medications. In fact, he found that people who had never heard of Tuskegee were more likely to fear medical research. So invoking Tuskegee is not based on the facts. In fact, calling this vaccine hesitancy is also not based on the facts. It's an assumption made because fewer African Americans obtained the vaccine. However, what people aren't asking themselves is why. You mentioned the 10% figure. The 10% figure has to be looked at in numerical context. African Americans make up 12.3% of the population at the time that 10% figure was found. And so a 10% figure is very consonant with African American population. We were showing up for trials. We were showing up consonant to our numbers in the population. So there was not any hesitancy in terms of joining the clinical trials. In terms of vaccine, again, assuming that its hesitancy is not supported by the facts, there are several reasons why African Americans have less access to the vaccine, and we need to look at those as well.
What about the stories that are out there circulating the Black community that, beyond what you were saying about vaccine hesitancy, but just some stories out there just basically denouncing vaccines, saying it's just not good, and they're arguing that they have natural immunity, and there are allopath versus homeopathic ways of treating this virus. What do you say to that kind of argument that is surfacing in some circles of the Black community?
Well, I say that we have to look at it in context again. Certainly some people believe that. The question is, does it represent the beliefs of most African Americans? You know, when you give a story, a narrative, it can be very dangerous. The narratives are presented as if they prove African Americans fear the vaccine, but they don't. They prove that some people, including African Americans, fear the vaccine. The policies that separate Black people from the vaccine include things like prioritizing the elderly. African Americans and Native Americans and Hispanic Americans are young populations. We have far fewer elderly. So if you prioritize people who are 85 and older, you're actually having a priority standard that works against African Americans who are not going to be part of that group at the same proportion. 90-year-olds in this country, you've got twice the rate among whites as blacks. So that's one problem we made. We needed a more nuanced policy that would protect the elderly and also protect African Americans. We didn't have that. And the other big policy difference error I think that we have made is by limiting for a very large time, limiting access to the vaccine through internet signups. African Americans are less likely to have effective internet access and also more likely to have to work outside the home, where they don't have the luxury of going online and checking vaccine sites periodically. All these things have to be internalized and refined, where our next policies don't work against African Americans. And none of these have been effectively discussed in the news media, unfortunately.
Mm. Mm. So let's effectively discuss it right now to get beyond the misinformation and the false narratives that are out there. What has to be done?
What has to be done are policies that increase access to all, for all. Right now, the policies favor people, again, who can work from home, who have internet access, and who have a lot of elderly in their group. We don't have a lot of elderly in our population. So we have to change the policies and refine them, not just the elderly, but also figure out how to get access to African Americans in a greater numbers. One error we're making that we don't have to make in the future is that prioritizing healthcare workers on the front lines, absolutely the right thing to do. The problem is we're confusing risk and social status. Hospitals, the people feeding the patients and cleaning the floors and preparing the dietary, these are people who are more likely to be people of color, and they are low status, and they need to be prioritized as well. So by using our mistakes that we've made now and refining the policies to encompass more people, to not operate against African Americans, we can go a long ways to increasing the number of people who get vaccines.
Welcome back. We're joined now again by medical ethicist Harriet Washington. She's also the author of Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present. So Harriet, here we are, as we were talking before, about the problems that are stemming from the vaccines and the COVID-19 pandemic. When you talk about medical apartheid, what is it that you're saying that applies to Black people getting vaccinated against the COVID-19 coronavirus today?
I tend not to use the term medical apartheid to refer to vaccination. However, if you do use it, it's a parallel to the South African system where you've got a very separate system for Black and white people. That's what's going on here. We have policy failures that affect people of color. And we also have Black people who have a very different health profile. They're less likely to have their personal physician. They're less likely to have insurance, less likely to have access to a hospital. All these things are systemic and institutional, and we have to change the institutions and our policies. The focus on African American behavior is misplaced. It's not the problem. An untrustworthy healthcare system is a problem, and we need to focus on policies that will make it more trustworthy.
You know, Harriet, what you're saying is really important, and I hope people are really listening. The bottom line is that I think only 30% of Black Americans have rolled up their sleeves to get vaccinated. What do we risk if the rest of the population within the Black community fails to get vaccinated?
Well, it would be a disaster, of course, not to be vaccinated. And it's important in finding a way to maximize vaccinations to attack the real problems, the real barriers, and not these mythical barriers. If there are fears of vaccines, we also have to address the fears. But I think it's very important not to lose sight of the fact that we're not always looking at people who are fearful. We're often looking at people who simply don't have access, and we need to address that.
Very, very important. Medical ethicist Harriet Washington, we thank you for joining us, the author of Medical Apartheid, The Dark History of Medical Experimentation on Black Americans from Colonial Times to the Present. We thank you again.